should zoom in. So intro, case, and conclusion. So the introduction. Statistics from the States, there's about 4 visits per 1,000 that are due to adverse drug events. That was from a retrospective study though. And a bit more than a quarter ended up hospitalized. And when you looked at the cases, a third of the cases were in the elderly. In Canada, from a prospective study, we see a lot more adverse drug reaction that are causing visit to the emergency department. Like we're 5 in 100. So, and when you look at the literature, it's always the problem. Like it depends if it's prospective or retrospective, basically. Obviously, when we look for it prospectively, we'll find more data than if you go retrospectively. And then just as an aside, like in Quebec, if you want to have an idea of the number of visits you would have, let's say in the emerge, like we have 3.7 million emergency department visits last year. So it's about like 10,000 per, did I do that? Yeah, 10,000 per day. So if you do like 5 in 100, that's a lot of visits basically every day in Quebec that are due to side effects that are happening from drugs that are given outside the emergency department. The problem is we don't know what's happening in the emerge. Like we don't know for drug that you're going to be giving, what's the amount of side effects we're going to see. But we're going to review a bit in the cases some of the side effects that could happen in the emergency department where we give like our usual drugs, but with weird side effects. So let's go. Case number 1. So it's a 17-year-old male that came with a sore throat, tired butt, end of school trimester that was started on amoxicillin. And then a week later, the patient comes back with the same symptoms and a maculopapular pruritic rash. Anybody has an idea of what could be happening? In the chat. Whoops. Yeah, it's simple drug rash, mono, amox reaction. So basically, scarlet fever. So the thing is, there's, I think it's a bit of it's becoming more controversial. I was reviewing that over the weekend, and then, so rash secondary to amoxicillin is somewhere between 2 and 10%. And then if you have a rash with mono, it's 3 to 15. But if you mix both, you end up with, it's anywhere from like 30, 40, up to 80 to 90% of rash when you combine basically a penicillin with mononucleosis. Usually it'll resolve after stopping the drug. What's recommended now more and more is to still do an allergy testing just to make sure that it was that combination and not a real penicillin rash. And what we're seeing right now, we're seeing actually that same amplified rash with other antibiotics like the cephalomacrolides and quinolones. So, so you still have to, some might say mono, but I think that's just ampicillin. So that's the thing, like you still have to probably do an allergy testing just to make sure, because that person's 17 years old as well. And then there's still a long way to go and probably need for antibiotics in the future. So, so just have to be careful in that kind of situation. Case number 2. So it's a 26-year-old female of Greek descent with multiple UTIs that are now resistant to ciprofloxacin. We just got a prescription for trimethoprim sulfamethoxazole, which is Septra or Bactrim, depending what how you want to call it. Double strength 1-PAP POBID. Comes back 4 days later with fatigue, shivers, tachycardia, hypotension, and hepatomegaly. Oh, we talk about G6PD from Robert. So let's see what's going on. It is actually correct. So the population from, it's often around the Mediterranean Sea, and I think there's some in Middle East as well. Glucose, so your G6PD, you see, or I'm sure you've seen that before. It's just as a refresher what's going on basically. So certain drug will act as oxidant stress, and usually will be the oxidation will be taken care of by the that NADP and NADPH, which is basically not working so well in the patient that are G6PD deficient. It's the prevalence is 5 to 25%. Like I think I've seen a case in the last 2 weeks here, which was kind of a bit of a surprise. Like we don't see that that often. I think at the MUHC, it's often asymptomatic until like you basically get a drug that will tip you over. And in the younger one, you'll get neonatal jaundice, and then usually in the adult, it shows up as an hemolytic anemia. So you stop the causative agent and you just support the patient, and it should be fine after that. Drugs to avoid, which is not a comprehensive list, but the few one like you see there, your sulfamethoxazole, which is here, and then the other one that are kind of a bit of a related sulfa drug, as well as the methylene blue. Another disease that you have to be careful with drugs is represented by this graph right now. What do we think, what are we going to be talking about as well here? Yeah, exactly. Which is funny because we had 2 cases in the last 2 weeks as well in the emergency department, which is we see some during the year, but like 1 a week is a bit of a biased data. So antibodies will basically work against the receptor for acetylcholine by either damaging or blocking the receptor, which basically causes a reduced muscle strength. So again, some drugs to avoid that can cause exacerbation, some antibiotics, some cardiovascular agent, and some miscellaneous like lithium, chlorpromazine, muscle relaxant, levothyroxine, so on. The list goes on. And the one thing you have to remember is be careful when you intubate those patients. I'm not gonna go in like length for the intubation, but just think that if you have less receptors, well, you'll need probably less succinylcholine to basically cause an action, like a potential, like a contraction, and then after that it stops. Your patient is basically paralyzed, ready to intubate. And if you have less receptors, then you'll probably need, if you have less receptors, you'll need more sucks. Sorry about that. So if you have less receptors, you need more sucks to cause a potential of action, and then a contraction, and then paralysis. And then if you have less receptors, you'll need less rock to block those receptors. Sorry about that. Case number 3. Okay. 27 years old, homeless, coughing a lot, came for a forearm abscess drain that is known for MRSA. And because it's a homeless, didn't want to stay, we gave him a prescription of linezolid, 600 PO twice a day. First dose in the emergency department, and then he's found 8 hours later in the entrance of the ED, because, I mean, He probably went out, came back with some hyperthermia, confusion and agitation, and hypertonicity. And in his coat or jacket, whatever, there's cough syrup bottles. Yeah, so the Maui, the linezolid acts like a Maui, and then the DM that's in the cough syrup is another drug that basically can act a little bit like the like a serotonin blocker. So you end up like with lots of serotonin on board and that serotonin syndrome. So there's always some weird agent that we sometimes forget about when we think about that. Linezolid being one of them, the DM as well. But I mean, I'm sure we've learned like the meperidine and sometimes fentanyl as well, tramadol. So there's a lot of like hidden potential. And then usually, so support is always a good thing, cooling, treating the agitation, the hypertension, intubating, and then the cyproheptadine acts also as an antagonist of the receptors. And then just because some people spoke about the neuroleptic malignant syndrome, it's a bit similar in its presentation with a bit more of a gradual onset. About like less than somewhere between 0.2 and 12% of the patient receiving neuroleptics can develop that syndrome, and with a mortality of like 5 to 11%. So the agents, so typical, atypical antipsychotic, metoclopramide, lithium, removing or withdrawing anti-Parkinson medication like the levodopa-carbidopa can do that as well. Treatment, again, support is always a good thing. And then you can also use dopamine agonists like bromocriptine and then muscle relaxant like dantrolene, which is kept in the OR in the MUHC. So, and it's pretty much everywhere in all the hospitals. That's the place we keep the dantrolene for the OR, and it's based on the number of room they have. So if we need it, like you always have to go to the OR, like we don't keep it in the emergency department. So let's keep going. So case number 4 is the 57-year-old male vomiting fresh blood on the pantoprazole IV infusion. Went to the endoscopy suite to get a G-scope. So left the emergency department and came back sinus with a SAT of 91%, but asymptomatic. So what's going on? Okay, so what would be the culprit? So Robert says methemoglobinemia. So what happened in the for the G-scope? Anybody? Benzocaine. That's in the spray. Yeah, exactly. So often they'll spray in the back of the throat, like lidocaine, benzocaine, whatever they're going to use. And sometimes if they use too much, well, that's what can happen. So here you have like a quick picture of the mechanism, like how your hemoglobin becomes methemoglobin. So it's either acquired or congenital, in the case probably more acquired. So local anesthetic, like the people were saying in the chat, and also the nitrates, like so the whole like nitrates, nitrites, nitroglycerin, dapsone and sulfonamides can cause methemoglobinemia. So treatment usually oxygen, methylene blue, and well, we can do that here, but you could go all the way to hyperbaric oxygen if you're refractory to treatment. Case number 5, 58 years old female brought by ambulance for chest pain. No nitroglycerin was given because of hypotension by the paramedics. And then BP 121/78 in the emergency department, still having chest pain. And then a new nurse, you see a new nurse kind of fighting a little with the patient, but succeed in giving her nitroglycerin. And now the BP is going down fairly, like a little more like what you would normally see with just one puff of nitroglycerin. So what's going on with her? Inferior MI, right side, I don't know. So is there something that the lady could be taking? Oh, okay, I like that. So not for incontinence though, that she would be on PDE5. So her usual medication is Revasio, hydrochlorothiazide, and pantoprazole. So the question is what, yeah, Xavier, it's a female. I don't think it works that way, but anyway. So Revasio is basically sildenafil for pulmonary hypertension. So the problem is it's because it's not sold under Viagra, people won't necessarily like know that it is sildenafil, and that's why the nurse was fighting a little with the patient, because the patient knew she was not supposed to be getting nitro, but like, you know, the nurse knew better, so she said, you need that nitro. So just like sometimes when we don't get that medication list, or when we don't know what the medication that the patient, like you have the list, but you don't know what they are. Like I think it's important sometimes to just take an extra second or a minute, whatever, to just make sure that you know what your patient is on before intervening. Case number 6, 19-year-old female college rugby player with a past medical history of asthma and seasonal allergies with wrist fracture. And you have the orthopedic resident that came down to do the reduction. And then you kind of hear the monitor beeping, and the nurse kind of like not feeling so good because the resident's on his own with RT. And then there's an O2 sat that's going down with stridor and noisy breathing. Patient had received ketamine and propofol. So laryngospasm secondary to ketamine. Oh yeah, Becca, I saw Becca's answer. Yeah, so laryngospasm is a fairly rare but possible side effects with ketamine. Usually doesn't last too long. Should probably get better with oxygen, and then if it doesn't, well, the only option left is to like intubate, probably if the patient doesn't get better with oxygen. Some people say that asthma might be a predisposing factor, but I mean, it's not well documented. Like there's a case review in pediatric with 2 of the 4 cases that had asthma. So it's just probably something to like keep in mind, but not necessarily like focus on. Low dose succinylcholine. Well, I mean, if you do that, like you'll be intubating the patient, like hopefully, like you're not gonna, like I don't think I would necessarily just give succinylcholine if that's SCH4 stands for, like just to like relax the, because I mean, you're going to be paralyzed for 6 to 10 minutes. I'm not quite sure that would be like the safest way to go. And the attending can jump in that case if they feel like it. Yeah, sucks last resort. I would agree with that. Sucks as last resort. Case, people still, okay. Case 7, 25 years old male, bike versus car with multiple fractures, with a pain score at 10 out of 10. Fentanyl, got something like 300 milligrams of fentanyl, 300 micrograms, sorry, of fentanyl, and some midazolam for the multiple fractures. And then suddenly his O2 sats started to go down, and even when you give oxygen, it's still on its way down. Chest wall not moving. Yeah, chest rigidity. We had a case, it's been a while, with Dr. Chermignani. It's kind of it's worrisome and a bit like freaky at the same time. Like the chest becomes like basically like stone, like it doesn't budge, like it does nothing to do. It was very transient, the case we had, like, and it was not that high of doses either. Remember loss on spine pressure from a weight case for laryngospasm. So yeah, so the mechanism is unclear. It's reported with several opiates, not just the fentanyl. It's more coming from the anesthesia literature. It seems to be related to the amount and the rate at which the drug's given. Might be potentiated by benzos, but it's not really clear. You could try low dose naloxone, and otherwise, like, you end up basically like intubating and like paralyzing and intubating if it's not reversing. But it's like I said, the case we had was very short, but it's like, it always like seems like it's lasting forever when a patient's not like doing so well. But it's yeah, you need to think about it. Like I think we don't usually give them probably fast enough or in large amount enough, because they're often prepare 100 micrograms at a time in the recess. So like the chances are probably like maybe a bit low. That's probably why we don't see it as often as they see in the DOR, but it's always something that you need to keep in mind. If we keep going with that 73-year-old female that fell from on height with an unknown past medical history and medication history. Glasgow of 8, heart rate of 67, and a BP of 101/65. And let's assume she's a full level of care. So Etomidate was chosen based on a hemodynamic. By the way, Etomidate is now on the Canadian market, meaning that for now we still have the same restriction at the MUHC. We'll probably be looking into modifying if people want to use it for more than we are doing right now, and to use it, let's say, for a procedure, like we'll have to, people will have to ask for a modification of the indication of the MUHC, but it's not on the Canadian market. It's not anymore a special access drug. I don't know why. I don't know if it was the pandemia that kind of like push the company to bring it on the market, like knowing that they were back orders for the other medication. But yeah, so it's available now in Canada. So the lady is intubated with Etomidate and succinylcholine. And shortly after the medication are given back to back, the patient has some mild cloudness for 15-20 seconds. Succinate potassium leakage. Etomidate. Ooh. Yeah, etomidate can cause myoclonus. The thing is, we rarely probably see it because your paralysis will kick in probably before the myoclonus will start. In certain anesthesia studies, which they usually don't really like the etomidate, it's reported like being quite frequent, and I don't know, it's because they intubate and like don't do the rapid sequence intubation like we do in the emerge, that they see it more, but the percentage is quite high when you look at it. Mechanism is unclear. They don't know if it's a disinhibition and a subcortical versus a real convulsion. It's really short duration. Predisposing factor, people say maybe if you're known convulsion, you might get more myoclonus with etomidate. Some people say you could use benzodiazepine at the same time. I mean, if you're intubating the patient, then you probably should follow with a sedative agent like propofol, which should do the same trick than benzodiazepine for the convulsions. And then if we keep going, now, last case. What do a 9-year-old girl in the PICU and a 35-year-old man in ED have in common? And I think we have a bit of time, so we'll spend a bit of time on that case. So what do they have in common? Both sick, both human. Okay, let's try to. Both are continuously seizing, but why? Whoa, isoniazide. Okay, allergy to hospitals, could be. They could both have coronavirus. Seizing, no, sneezing, sorry. Withdrawal. Withdrawal to what? Oh, I saw seizing too. Wait, did I? No, I wrote sneezing, sorry. Okay, let's keep going. The young girl, but withdrawal works, yeah. The young girl got extubated after being ventilated for 3 weeks, while the man is an IV drug user. So yeah, no, you're definitely in the right direction here. So midazolam infusion of the young girl were stopped just prior to extubating her. And the man received naloxone. So I'm glad you saw it fairly quickly. So naloxone and opiates withdrawal, like there's the common one that we see, and there's the weird one as well, the weird signs of withdrawal. So tearing, sneezing, yawning. So sometimes I'm sure you've seen them, like they have a rebreather on their face, and then they often try to like scratch the nose after getting a naloxone. I had a case when I was in the States, basically, it was funny and not at the same time, but like she kept sneezing every like 2-3 seconds. It was like for like 15-20 minutes. It was a bit funny and ridiculous at the same time. So yeah, so just like naloxone and opiates withdrawal is always interesting, like sometimes weird effects or side effects when you look at it. So yeah, so conclusion, drugs can cause side effects based on sometimes the condition that we know or don't know sometimes. Drugs can cause, I'll answer that question about Suboxone after the conclusion. Give me a sec. When you add drugs with similar effects, you can get like more side effects as well. If the patient's on certain medication or natural products at home, that can also cause side effects, and sometimes can be lethal if unidentified. And then we're always there, unfortunately, 40 hours a week. But when we're there, please, we'll be happy to try to help you figure out what's going on. For the Suboxone in the emergency department, there's no protocol per se right now. We've been using it in a few patients in the last few months, I think. But if it's something that we think we should have, so we can initiate and like do Suboxone induction in the emerge in that kind of population, like we'll eventually maybe look into it. But I mean, right now there hasn't been formal requests from the emergency department to look into it more more seriously, I will say. And then to finish, so I stopped taking the medicine because I prefer the original disease to the side effects. So if there's a bit of time for questions, if people have questions.
Doesn't look like we have anything else, I don't think. Okay, thank you so much, Eric. That was a really excellent and useful talk. Thank you.
You're welcome.